I'm going to start I'm going to try and take less than 2 minutes to kind of give us what I think is the state of the state, to kind of get our discussion started. In late March of 2020, ATS recommended that we all stop doing pulmonary function testing unless it was going to immediately impact the care of the patient. So I could certainly see in some patients with an exacerbation of asthma or question of lung rejection, and that was kind of all that was being done. And most pulmonary function labs came to a grinding halt because of that recommendation. As of yesterday at about 3 in the afternoon, that is the most recent ATS standard that I could, or recommendation that I could find regarding pulmonary function testing. We were promised an ATS recommendation in early March. The European Respiratory Society, or ERS, came out with a recommendation that talked about spirometry in the peak virus season, the post-peak virus season, and then the we're back to normal season. I think I would argue right now that if we're probably, I'd like to believe that we're in post, I think we can use the post-peak recommendations for probably everybody that's on this call right now. Although that certainly could change if things get worse in our various areas of the country. But I think we're all kind of from the middle Atlantic regions, or middle Appalachian regions. So the hazard that we're worried about is that when you have somebody do pulmonary function testing, is that you're having them as part of the forced expiratory maneuver that's part of normal pulmonary function testing. You are having people exhale forcefully, and people are concerned that that would increase the spread of virus. Obviously, you can't wear a mask while you're doing that. And there have been several other things where people are exhaling forcefully, especially in singing, is the one that's been the most caused the most often, where they've had some spread and even what some people call super spreader events related to singing. That's why I think that's part of why people are worried about pulmonary function testing. The technology varies quite a bit between pulmonary function testing machines. Some machines have intrinsic filtering, many do not. Many of them, if you look in the patient end of the apparatus, and you look out the other end of the apparatus, there's nothing in between. And some have stuff that I'm just going to call window screen, which is really not much of a filter, and some have actual filters. I'm just going to, for a second, step back to my occupational medicine roots and just note that if you can kind of put the same filter that's in a respirator in an actual legitimate like N95 or N100 respirator in that pathway, you probably are going to markedly decrease the amount of material that goes out into the room. Although people can still cough or breathe around the tube, it doesn't take the risk to zero, but it does, I think, decrease a little bit. At this point, what I'd like to do is, I'm kind of curious because we have probably, I should have written them all down, but we probably have 10 different pulmonary function labs represented here. And I'm really curious where people are in restarting spirometry for non-critical patients. So I'm not the lung transplant patient that you got to get it done, but the people that were it's, for diagnosis or maybe even for benefits testing. I don't know what the best way to do that is. I guess
Hey, Dr. Warren, sorry, we lost you there for a second. Could you repeat your last statement?
Sure. What I was hoping to do was kind of go around and ask the different clinics to talk about, have you restarted testing at all at your facility? And number two is, if you have, what are you doing special or different? Because right now without anything useful coming out of ATS, we're kind of left to figure this out on our own. And I would love to get other people's input as to what different clinics are doing. So I guess anybody that wants to share, please go ahead and do that. And we'll try to get, I'd like to hear from as many clinics as we can, because I think that's how we'll learn.
This is Brandy Bell at Lincoln Primary Care. I can speak for Johnny and I both. He's at our Logan County site, and man, we have not started back with our testing. It's been the discussion for the past 2 or 3 weeks that we will start soon. I know part of our starting back with our testing is we're going to be using bacteria filters with our spirometry that we ordered from McKesson. We are going to have the patients be COVID tested at least a week prior to, until there's some form of rapid testing available. We're going to wear our full PPE. We actually have videos on YouTube available with our machine specifically that show how to do the different maneuvers that we're going to try to allow the patients to watch videos for better understanding, since we're going to be completely, gowned up. It's going to be a little more difficult to explain it to the patients. We're still, I know our lung doctor is still going to be very, very specific to who she's referring to us for the next few months. Besides that, we plan on getting on a call. It's just not happened yet, but with Johnny and myself and our lung doctor and our COO and our medical director, all of us on a call to make sure Johnny and I are going to, have it, in black and white, exactly what they want us to do. I know that we're going to allot for an air time of like 30, 45 minutes, and then a clean time before we would bring anyone else in. And I know my game plan was to do one in the morning and one in the afternoon, because right now we're not back to pulmonary rehab, which allots me 5 days a week to do PFTs and just really spread them out, because we have to share the same waiting area space as our lung doctor. So we don't want a lot of our patients, mixing and building up in the waiting area. But it's going to be different for sure. I know the biggest thing is getting them COVID testing and getting that back negative before we even do the PFT on the patient, and trying to stay back away. I don't have a negative pressure room. I don't think Johnny has a negative pressure room in his new clinic. So, and we're in my area, I'm in a hallway where we perform like 6-minute walk tests with our other patients and things. So there's going to be a lot of different things that we're going to probably be trying to change just to eliminate traffic in the area that I'm usually in. But there are 2 doors that I can shut during the actual testing. So that helps. And of course, keep those doors shut after they leave while we're going to be waiting to clean and things. But we're working on a policy before we can start back. But I'm kind of like you, Carl. I was really hoping that the ATS was putting something out soon. But I keep looking and not seeing it. But I think it's probably going to be really similar to the European model. But that's what I'm doing at Lincoln Primary. And Johnny, if you want to jump in and add anything that I left, go right ahead.
No, the only thing I put on there on the chat group was that the way I feel kind of like if we actually started doing peak flows, and to me that's pretty well worse than a PFT. And I kind of like, we might as well just go ahead and reopen if we're going to go ahead and do that. But that's just my, I guess, view of it. I'm not somebody that either halfway does something or halfway doesn't do something. I kind of like to go for it. But what do you do? So we have to get back. We have to do something. I think maybe it's going to be kind of watching your local population and see where they're at with the COVID markers, see how many are actually positive. Everybody talks about, well, we're actually starting to get a few more positives out there, but we're actually doing some more testing. It doesn't mean that they weren't there just because we're testing. It just means that we're finding out that there's maybe a few more there. I don't know the answer just as much as anybody else does, I guess.
Well, thank you guys. Would anybody else like to share where you're at? I'm especially interested if anybody's actually opened up at all and is doing any testing.
This
Hi
is
guys,
Allison
this is Lisa.
Sela.
Oh, sorry, Allison.
No,
I'll
go
be-
ahead. Go ahead, Lisa.
New River Health has not opened up for testing. That's going to be happening. I just now finally got off the front line so I could come down here and do some work on this. um, we're going to have a universal mask policy down in the breathing center, of course. One of the things that I'm doing to try and get me further away from my patients is my laptop sits on top of my machine, and they can, and pretty much it doesn't matter where you move the mouthpiece, they're blowing towards me. So I'm working with IT to get my patients facing a different direction and my laptop outside of the room. We're definitely rearranging our breathing center down here. So I'll, be able to control the, the equipment from further away from them.
Do you think you can actually do, that's interesting. Do you think you'll be able to guide the patient without being in the room?
No, I'm right there, like kind of like at the door. It's a very small room. Yeah. Oh no, I'm the cheerleader. I'm right there for them, but I'm not going to have them coughing and blowing towards me. So I'm just getting a little further away from them. So you have to imagine a closet, Dr. Words.
Sure.
Okay. Imagine a closet and imagine you just being right there at the edge of the closet.
No, yeah, that makes sense. Are you guys planning to wear PPE, like, N95s and gowns and everything?
Absolutely, full PPE. Like I said, I'm getting out of their directional flow. Okay.
Sure.
So my laptop's going to be a little further away from them. We are going to be dressed and full PPE. And then an hour air out time, probably wait, 45 minutes, and then doing cleaning. We have always done neb treatments, so we'll be switching to MDIs and with spacers, of course. So that'll be new for me. I've always done nebs. We're going to be, we're going to talk to the patients upon, scheduling them. We're going to offer COVID testing and show them where they can get it in their community, especially if it's a minor that's coming from far away. Right now, New River Health is doing COVID screening on Wednesdays at our new proposed site that we're going to be at. And but I think we're going to wait to see how it is in our community as far as if we're going to make that mandatory. And as far as the COVID testing right now, it's billed to their insurance. If their insurance denies it, there'll be no copay and no charge to the patient. So it's not free, but there's not a charge to the patient at all because their insurance is going to be billed.
So Lisa, let me ask my question this way. Isn't there still some community-based testing? Is the one down at the Boy Scout place still open, or has that gone away?
I think that it is still open. I just know for a fact, here's some hours and you can definitely get this done here. We're going to offer the testing, but it would need to be done the week before so that they can get their results back. It seems like it's taking about 48 hours to get results back. So like if they had it on a Wednesday, we could follow up with them on a Monday and get them in for their test on Tuesday. But most definitely screening them with your classic COVID questions, 72 hours before, calling them the day before their test, asking them the questions again, and then screening them at the door. So, and we're only going to have one patient in the breathing center at a time. So that's kind of where we're at. We don't have a negative pressure room. And because we are, moving out of this building eventually here in the next year, I don't know if they're going to get that on board. I would like to, one of my questions to you guys is about certain types of HEPA filters that could be in the room. Have y'all done much research on them, and what have you found out? Because that would be some type of, filtering out the air that's in the room. So I'm just, that's going to be my group question is, have y'all done research on filters and how effective are they?
So I'm gonna give a partial answer. which is the HEPA filter thing goes back to testing CF patients.
Right.
And the CF Society, I'm not sure, I probably have the wrong name, but the CF advocacy group has recommendations for pulmonary function testing in CF patients. And they seem to be I don't know, 8 or 10 years old. And that's where the HEPA filters came from, was that you would, they actually did research looking for a couple of the CF specific pathogens and found that that you can use the HEPA filters to decrease the prevalence of those. Now, the problem we have is that the European Respiratory Society specifically recommends against them because they're afraid of colonization.
Okay.
But there are some now that have a UV light source that it shines on the filter. So it's basically disinfecting the filter continuously. I just went and looked at the here at Preston, they're using a HEPA filter unit in the PFT room doing like today. And that one does not have a UV light source. I just went and looked at it. So it has what looks for all the world like the HEPA filter that you would buy for your home heater system that sucks air through it, and it turns over the air faster through the HEPA filter. That's basically what the one that they have here does. It's got a big exhaust on the top of it that blows back into the same room. So it just kind of takes all the air through the filter and then blows that into the room. The European Respiratory Society recommendation was they were afraid of colonization of the filter and then it being re-aerosolized later. I'm not sure, this is now Carl's opinion, not backed by any science, I'm not sure that that's a real risk now that we know more about the virus as compared to what they thought before. We used to think that it lived on inanimate objects for hours and hours or days and days, and I think I don't think that's really true. But it has to do with the kind of testing they were doing for that early on. They were just looking for the viral DNA, and the viral DNA doesn't indicate that there's live virus there. And so I'm hoping that some of that testing has been redone. I don't know if they've done filter material or not. But you have to actually take it and then culture it out to see if you've still got viable virus or not there. So that's an area that hopefully that science will evolve in the next couple weeks. So we'll actually know if that's a good idea or not.
Okay. Well,
anybody else?
Guys. That's what I have to update. We haven't started, but we're getting started. And I know Dr. Doyle really wants to have solid policies before we let one person walk through that door, and we will.
Yeah. Anybody else want to share?
Yeah, this is Allison Sela at Preston. Like you mentioned, we do have the HEPA filter. We started testing probably about a month ago. And our policy, let me get it pulled back up here. Where did it go? Sorry. With our policy, everybody is being tested prior to coming in for their pulmonary function testing. They have to have a negative test before we'll do their PFTs. And then when they get to the hospital on the day of their testing, they're also being screened. So all staff is using PPE, masks, goggles, gloves, and gowns when performing any cardiopulmonary procedure. We are scheduling at least 30 minutes between patients. We're using expiratory filters and single-use devices and components as much as possible. And then again, things like washing hands. Patients are getting instructed in cough etiquette, and they're getting tissues. They can cough into the tissue as much as possible. And then in between each test and effort and maneuver, the patient has to wear a mask. And so that's what we've been doing so far. And again, testing everybody to make sure that they're negative before we even bring them into the hospital. And we've been doing this for about a month now, and it seems to be going okay. We've not had any problems that I've been aware of.
Well, thank you very much. Any other facilities want to share, especially in some of the Pennsylvania places where you guys are, I think, a little bit behind. You guys have had more disease prevalence in the past. I'm just curious how things are going up there.
Hi, Hi, this is Caitlin from UPMC Altoon's Black Lung Clinic in Pennsylvania. So
Sure, go ahead.
the pulmonary function department is right beside my office where the clinic is. And they've been doing pulmonary function since May 4th on patients that just really needed it done for some particular reason. Maybe they're starting chemo or they're having a lung reduction surgery or something like that. And that lasted about 2 weeks or so. They had to have a COVID test within 3 days of their breathing test. It had to be negative. Of course, there was screening, and then we have a HEPA filter and the full PPE with the N95 and everything. So that was until about mid-May. At that point, the floodgates opened and they started to allow any patient. And we've been doing them just back to back to back every day because we're just overloaded with patients from not being able to do them for, you know, a couple months. So there's an extreme backlog of patients right now. So they stopped doing the COVID test before the breathing test, maybe about 2 weeks ago or so. And that was a general UPMC rule. And there's, I don't even know how many hospitals in Pennsylvania that are UPMC hospitals, but they tested thousands and thousands of people when they would come in for a surgery or before a pulmonary function test. And out of the thousands of people, about 1% of the population that they tested had a positive test, a positive COVID test. So they didn't feel like it was worth testing every pre-op patient, every patient coming in before PFT, because the prevalence was so low. So they didn't want to waste resources and waste testing on that. So they do some rapid tests here if the patient's at high risk. And I think that they test every patient that's an inpatient. But other than that, we aren't doing before the PFTs anymore. And even at the 3 days, honestly, they could go to Walmart that day and pick it up, you know, and then 3 days have passed and they're positive when they get here without even knowing it. I mean, so that's a possibility. And then today we're starting to see black lung patients in the clinic. So we have our first patient this afternoon, and we'll be in full PPE while they're on the treadmill and we're getting blood gases and while they're doing their spirometry. Oh, and we're also in a negative pressure room here in my office.
Oh, there you go. You're lucky about that.
It's an old bronchoscopy suite, so.
That's still, I think that's helpful. And are you guys still leaving a time? Is there a rest time between patients, or do you just go, are they literally just stacked?
They're just stacked back to back. Yeah.
What?
They have the HEPA filter running constantly, and they clean, you know, in between. But there's just not enough time. And like I said, the prevalence is so low in Blair County where we are. I think we only have around 50 some cases for the whole county, and there's probably 150,000 people in our county.
Mm-hmm.
And it's a big city where we are, so.
Sure. And so, yeah, because like I'm just gonna, like, a 1% positive rate is I would say is not small, but that's just me. But I appreciate it might be much lower than that at your facility than it is in, you know, downtown Pittsburgh.
And what I can remember, and this is just from listening to like the UPMC news conferences and stuff, I feel like they tested 10,000 people and one was positive.
Oh, yeah, that's a lot less than 1%. Okay.
Yeah.
So.
I mean, UPMC is huge. They have, I don't even know, probably 30 hospitals.
Mm-hmm.
And then, of course, how many hospitals in Pittsburgh that they're testing people at?
Sure. Anybody else want to share?
This is Dean Gunner, Pocahontas Memorial Hospital. We started 2 weeks ago, but we've only had about 6 patients come through. Our patients pretty much all come from one pulmonologist. He's screening before they come. We're doing the inhalers, employees wearing the PPE, it's gown, mask, gloves, big face shield. And we're trying to get them to bring inhalers. We have one patient that we couldn't do inhalers with because they couldn't actuate an inhaler. And we had to use a band nebulizer with a filter. The filtered bands, if you guys are familiar with that, we used one of those to give them their bronchodilator for that test. We're lucky that we just had a remodel in our room that we're doing PFTs in. It's actually, it vents to the outside. It is not negative pressure, but when the door's closed, it doesn't really contaminate the rest of the hospital. So that's where we're at right now. Haven't really had a lot of cases of COVID here in Pocahontas County per se. But, right now, we're having a hard time getting people to schedule just because of, they got a outbreak there in Huttonsville, and then I think Greenbrier County had an uptick this weekend with the church down there or something. But otherwise, everything here is just kind of like everybody else, it sounds like.
So are you guys doing actual COVID testing of the folks at all, or are you just doing symptom screening?
We do symptom screening on the day of service before the patient has our turnaround time. Like the pulmonologist ordered a test, it's the same week. He's actually doing a screen, the COVID screen. He's ordering that, and it's coming back, and then he's sending them over BFTs post that. But,
oh, gotcha.
We're relying on symptom screening here, just with the temperature checks and all that stuff at the door, and then patient interview with, have you had any symptoms, cough, fever, and all that stuff.
Okay. Yeah. What's hard for that is that we always got to remember that approximately half, maybe it's 45% of people that are carrying COVID are, symptom negative. So that's a hard question. I think in West Virginia, as I understand it, and I don't do surgeries, I think they're still wanting testing I think it says its word is pre-procedure testing. And I know some hospitals, I think Preston has taken the stand that pulmonary function testing is a procedure, and so they're doing the pre-testing. But again, I don't know where that's kind of I think the way it was written, you could be interpreted locally in a lot of different ways. Does anybody else want to share?
I was just going to say, I think that part is actually independent. I'm scheduled to have a procedure done on July 1st, and they told me that as of now at Mon, I actually do not have to have COVID testing prior to just screening. So I'm not sure, how that's being interpreted. So.
Yeah, that may have changed. That in whatever week we're in of the 6-week plan, that may have been one of the things that was eased off on.
I had a question for you. Right now we're having a problem with cleaners. Like our cleaners, what we're having to use right now is a wet time of almost 20 minutes. And the turnaround time on that for just pretty much everything is really slowing things down. Like just being able to clean the room and clean your product. Does anybody else have a problem with getting, like the Sandy wipes and stuff like that? Or is that just us?
This is Brandy Beldine. I think the wet wipes, the cleaners, I'll put it this way, you have to go to a specific person to get a box of our wipes. They're not in all our storage rooms anymore. They're being very stingy with them because we are running low on those. That was with all the PPE initially, but now that we're back to bringing patients into our offices, a lot of people are rushing to get those at our sites. So there's like designated people at each site that you go to get those from, and they're keeping count of those because we're running low as well, Dean.
I agree. This is Lisa from New River Health. That's exactly what's happening here. They're under lock and key, and you have to see a special person to go get it.
Are you guys using like just the dilute Clorox or something fancier?
Clorox is fine at my site. A lot of it was, something a little fancier from like McKesson, a vendor initially, but a lot of it we're fine for just using Clorox or Lysol wipes. Disinfectant wipes are okay.
We have wipes that are made by Clorox, but those are something that's not. I mean, they don't actually have bleach in them. I can't remember what chemicals in it right now, but those are one of the ones that we are really having a hard time getting. The other ones are the they're hospital. They're on the
Sani cloth.
Santa Claus. There you go.
Yeah.
Yeah, those things are pretty much impossible to get right now. And
Yeah.
we're having to use cloth with just cloths in some situations, and cloth has a very long wet time that you have to, and you can't put some of this stuff on computer screens, or some it deteriorates plastic on some things, so you have to be careful about what you're putting on your stuff. But our PFT machine, we were lucky that ours is Morgan Scientific, but they sent us some actual wipes they recommended cleaning ours with for a while, but now we can't get those.
Okay. The other thing I'll say, just because this is a pulmonary function or a lung function group, focused group, is there are some of the disinfectants that are being used in the hospitals are a mixture of bleach and hydrogen peroxide, and just be super careful with those. They are an asthmagen. When they introduced those at one hospital I was working, we had a run of people getting occupational asthma from them. So if you use them exactly the way they're intended, where you open the container of wipes and pour the stuff in and and then put a cover on it when you're not using it, they're pretty okay. But if you leave them open, it's bad. And if you actually put it in a spray bottle, which we had people do, and spray down surfaces and then use the wipes to dry it, like you might clean a window at your house, that was especially bad. So just be mindful of those if they show up at your hospital, because I know that everybody's scrambling for disinfectants right now. Does anybody else want to share about what's going on at their hospital and what they've come up with as clever ideas to get back to doing pulmonary function testing?
I have a question. This is Brandy Bell. I have called 2 patients to set up PFTs for this week, and one of the 2 refused to come do the testing because they did not want to do the COVID test. They said they didn't think they needed a PFT that bad, and they would just wait until we weren't taking those precautions. I tried to persuade the patient in all sorts of different ways, but are you guys that have been open, are you running into a lot of patients that are just weary about coming into your site, or they don't want to have the COVID test ran?
Hey, this is Caitlin from UPMC in Altoona. In the beginning, when we required the COVID test, a negative COVID test before the PFT, there were, maybe 25% of the patients said they'd rather just wait until everything's over so that they didn't have to have the COVID test. Even though it's covered by insurance here, until they drive to the testing site, they do that 3 days before, and then they drive here and everything. They just didn't want to deal with it. But then other people that, they just didn't want to come out because of all of it. They didn't want to be in a hospital setting and potentially be exposed. So we did have some resistance to that at first, and some patients were upset that that was a requirement. And now, even though it's not required here now, still patients aren't comfortable coming out and about. Pennsylvania just entered the green phase about 2 weeks ago now at this point, but it's still not like wide open Pennsylvania. It's still with some restrictions, but we're better than what we were, a couple weeks ago.
Thank you.
Anybody from Armstrong want to talk about what's going on, what you guys are doing right now?
Hey, good morning. So we actually opened up our PFT suite probably about a month ago now. we changed that over into a negative pressure room, and we are doing our PFTs with PAPRs and full PPE. And then we actually are waiting about a half an hour afterwards to let the room kind of air out before. So we're scheduling our PFTs at 1.5-hour increments, as opposed to the hour increments, just to give that a little time to air out and whatnot. We also are only doing bronchodilators when necessary. So when our FEV1, FEV1 to FVC ratio and FVC apparently are normal, we are not proceeding with like the second part of the bronchodilator PFT part. We're only doing the spirometry part, which is kind of, we used to do that, and then we got into doing the full bronchodilator pre and post on most of our patients, probably about 95% of our patients. But now we're going back to, if they are a normal spirometry, we're not moving forward with doing the bronchodilator portion of it. So other than that,
Do you do bronchodilator by neb, or do you do it with an MDI?
we're doing it with MDI. Yeah.
Hey, everybody. I wanted to draw our attention for a moment over to the chat and take a couple minutes to do a couple of things. We've had wonderful conversations and comments over in the chat. Let's see, one of the questions we had recently, what are PAPRs? PAPRs, Aaron, of course, chime in. We use them in the hospital a lot. They're a type of PPE.
It's a powered air purifying respirator. So it's the one where there's a fan either on your belt or somewhere in the helmet that blows filtered air past your breathing space. That's what a PAPR is. And the nice thing about them is you don't have to fit test them. The bad thing is that they are somewhat noisy. And it's a balancing thing. But it's probably a nicer form of personal protective equipment if you have it available. And some hospitals have chosen to use PAPRs instead of regular respirators to the regular masks, to avoid having to do fit testing.
I'm just going to jump in one more time here. We actually left the option up to our technicians that are doing it, our respiratory therapists, and a lot of them actually prefer the PAPR over the N95 because the patients can actually see the mouth. Mm-hmm. So they're able to, I mean, when you're in, we have the body box, so when you're in that box, it's hard enough to hear, so at least they can kind of still see through the shield, see the mouth and rely on that part as well. But we leave it up to them if they want to do the N95 after fit testing or the PAPR, and they've all chose the PAPR to be, I guess a little more efficient and whatnot there.
Right, and I'll be honest, if I had to wear one for multiple hours, I'd want to be in a PAPR too. They're more comfortable, quite honestly. If you have them available. I know that WVU's gone, I think their basic plan was they went to PAPRs for everybody, but I don't know if with COVID, if they've had to change that a little bit. How about anybody from Cabin Creek want to add in what you guys are doing right now?
Luann, if Luann comes on, I'll yield to her. I see she's there. Here she goes. Go ahead, Luann.
There we go. I'm sorry, I couldn't get it unmuted. Thank you. At this time, we're still in the works of generating a protocol to start. So I know that the thought is mid-July to restart with our DOL testing. Our respiratory therapists right now are still out front triaging, so we've had very limited time to really generate everything as far as our processes go, but they hopefully, as of today, they're restructuring the out front triaging. So we're waiting to get some of that organized and then proceed further. We are not doing any PFTs at this time. That's still in the works. We're still working on the negative pressure room, working on the different equipment pieces. Now, there may be more that the therapists have, since I've talked with them last, have organized, but to my knowledge, that was the last that they had talked about. We are going to, when we finally do start up, they're going to stagger the testing, have less patients than normal. We're working on knowing that we have to have our PPE, obviously. I know they were talking about how to do it so that we weren't actually in front of the patient, because right now, the way our room is set up, that's what we would have to be. They were thinking on possibly using, we have another room that's just been built, maybe trying to do it in that section so we're not actually in front of them, but we're still in the works with some of that at this time.
Okay, thank you very much. Anybody else want to share or ask a question or discuss a topic in this area? Because the one thing that I will say from listening right now is I think every possible combination of having started, having not started, and having problems with it or not having problems has, I think we've got every possible solution here. And so I think this is great sharing.
Everybody, we have about 10 minutes left. I did want to take a second to have a few people who jumped on in the middle of discussion introduce themselves, just in case they had any questions to ask. Let's see, Stacy, do you want to introduce yourself? And I think everybody is muted right now. No worries, everybody can chat in. I see a Y Adair. And then Beverly Lawrence, do you want to introduce yourself? Okay, well, no worries. Everybody, you're welcome to chat in. And then I'll let you guys continue with this for 10 minutes. Let me know if there's any questions for follow-up afterward.
So the last thing, and Dr. Doyle prompted this, I'll just mention this, is that right now we're also in an evolution of testing. So if you're thinking about testing in your clinic, there's different kinds of tests that may be more acceptable to patients. I know he mentioned this in the chat. Some of them, I think they tickle your brain with the swab. Some of them, they just have to get a little bit of just into the nose or the posterior pharynx, generally, which is a lot more acceptable to the patients. The other big thing is that I keep thinking about, and this is for when I think about it, like if I want to get tested, is the most important thing to me is that I want to know you need to know what instructions you're going to give the patient when they go get tested. And what I mean by that is, initially, when they first started testing up in Morgantown, where I live, the instruction was that if you showed up for a test, even if it was community-based testing, they said, well, you've been
Hey, Dr. Wernz, sorry about that. We lost you there for a second.
And there's no such instruction. But just be aware of what that is, what the people doing the tests are going to instruct the patient of, because I think that also will change its acceptability. Any other final notes? Because I know we've got about 10 minutes here. Anything else anybody wanted to share before we wrap up for today?
Guys, I just wanted to say that this is Lisa from New River Health. I appreciate this session so much because, it is such a scary thing these are scary times and we all have these questions and are we doing it right? And just to have this soundboard and to have Dr. Wernz and Dr. Seela and Dr. Doyle and you guys to tell us what to do or give us suggestions and find out what everyone else is doing. It's really helpful. Because you're jumping into this wondering, like, am I doing it right? And then sometimes you really are doing it right, and it's okay. So I just want to say thank you guys so much.
Well, I want to share. I really appreciate everybody sharing where we're at, because this is without any kind of national level guidance. We're kind of all over the place, and sharing with each other, I think we can get towards best practices, which is where we really want to be anyway. And we're, I said, I think that these kind of events where we share is really helpful.
Caitlin, this is Dan. I got cut off about 5 minutes ago, and when I did, I lost all the chat. So I would really appreciate it if you would copy the chat. I use that utility to copy the chat and send it out. Although we're going to still miss private chat, so I'm not sure how useful that would be. Probably because you probably won't have everything.
No, that's fine. So the private chats, just a PSA for everybody. If you're ever in a different meeting, it doesn't matter a huge amount here. Private chats actually do download onto whomever the I don't know, moderator is for the session,
host,
whoever's hosting it. So never chat anything funky if you don't want the host to see it.
That's a great step.
Yeah.
Because Caitlin Grado sent a really interesting stats about system-wide UPMC testing. And I lost that, and I would really like to have that. Thank you, Caitlin.
Yeah, that's no problem.
And a question that it raises is, what is a low enough, this came up earlier with what Carl was talking about, what is a low enough system prevalence testing to say we don't need to do testing? And so her stats were really, really interesting in that respect. And we don't know that yet because we have to make it up.
Yeah, I'm going to argue that if they said that we did 10,000 tests and there were 0 positives, I would say you're right. You're probably not. There's no disease there to find. 1 in 400 positive rate. It's 399 patients you tested that it's annoying. Now the only question I have, this is the public health person in me coming through, is if that's one legitimate positive, if it's actually a true positive, and you can take that one patient out of 400 and handle them differently, or maybe don't do that elective procedure right now, then I think you've saved a spreader event. And it can, but again, if that 1 in 400, the problem we've got is that the positive negative predictive value of the test is probably not as good as 1 in 400. Does that make sense? So the question is whether did you miss more positives, or did you identify somebody's positive that really isn't when the population prevalence is so low? And that's the hard part about the testing. I keep praying for better testing, and it is getting better, but none of the tests we have right now are perfect. So when prevalence is that low, the test may not be helpful. And that's kind of, I think that's the hard part is, if I test 400 people and I'm going to find 4 people I'm going to call them a false positive, and only 1 in 400 is truly positive, did I really find anything? That's an important question.
So maybe, Caitlin, if you could look at the ECHO CLD schedule and think about when we might squeeze in a follow-up, have this session again 4 to 6 weeks down the road. That might be an idea, because things are changing and people are continually updating their policies.
Yeah, I can definitely look at that. Remember that in about a month, on the 20th of July, we are going to have another follow-up session. Hopefully at that point, ATS and some other places will have their guidelines released that we can discuss. But definitely we can discuss again after that. Any other questions, comments for this one? Or you guys are welcome to email or submit to the case form anything you want to follow up on. All right, my friends. Let's see, Dr. Sela, I have Dr. Sela continuing her NICE guideline discussion. She started the year out with it, actually, and we were going to continue it, and then COVID hit, and then everything fell apart. But it was a really great discussion. I'll send the YouTube link for the first part so you guys can kind of refresh what we talked about and why it was so interesting that we want to continue. Any questions about that, of course, send those in, and everybody have a wonderful week and stay safe. Thank
Okay,
you.
take care, everybody.
Thank
Stay
you
safe.
all.
Stay healthy.